Hello, and welcome to another episode of Podcast DX, the show that brings you interviews with people just like you whose lives were forever changed by a medical diagnosis. I'm Lita.
I'm Ron.
And I'm Jean Marie.
Collectively, we're the hosts of Podcast DX. On today's show, we are speaking with Dr. Karl Steinberg. Dr. Steinberg attended medical school at The Ohio State University and completed his residency in family medicine at the University of California in San Diego. He's board certified in hospice and palliative medicine and family medicine. So that's a triple board certified. Doctor, is that kind of like a...
Triple threat?
Well, no, the triple crown? Yeah. With
Triple,
the horse rack.
Well, I think a triple threat is someone that can sing, dance, and act.
Oh, okay. Well, he's a triple threat on the
As
mountain.
you can tell, we kind of just, we're a little lighthearted.
Yeah.
Dr. Steinberg is joining us today to talk about hospice and palliative care. Many Americans die in facilities such as hospitals or nursing homes, receiving care that is not consistent with their wishes. It's important for older adults to plan ahead and let their caregivers, doctors, or family members know that what their end-of-life preferences are in advance. For example, if an older person wants to die at home, receiving end-of-life care for pain and other symptoms, and makes this known to their healthcare providers and family, it is less likely that he or she will die in a hospital receiving unwanted treatments. On today's show, we will discuss the differences between palliative medicine and hospice care. Thank you for joining us today, Doctor, and may we call you Karl for the remainder of the interview.
Yeah, of course, and thank you for having me.
Thank you.
So, Karl, this is Ron. Again, thank you for joining our show. I guess the first question to ask is, why medicine? What led you to pursue medicine?
Well, I guess the simplest answer is my parents were both doctors.
Oh, okay.
In fact, yeah, my dad is 89 and he's still practicing psychiatry 3 days a week. And my parents both loved their jobs, so I grew up always kind of assuming that I'd follow in their footsteps. After college, though, I taught high school for a few years, and ultimately after that I decided I didn't want to do that for the rest of my life, even though it was a fun job and you have a vacation every time you turn around. But so I decided to go back to medical school, and I'm very glad that I did.
Okay, thank you. And Karl, what is the difference between hospice, end of life, and palliative care?
So there is quite a bit of overlap between those things, but I guess we can start with hospice. Hospice is a specific benefit under Medicare Part A, and there's certain requirements for hospice, but I think probably most listeners, would equate hospice with the care that you get when you're nearing the end of life. But so the requirements are, first, the patient has to have a 6-month or less life expectancy if their disease processes run their usual course. Now, that doesn't mean that they're going to get kicked off of hospice if they don't die right at 180 days. It only means that the doctors think it's likely that they will die in that time frame. Secondly, it requires that the patient basically choose comfort-focused care and treatment, which means like no more chemotherapy, no more transfusions, no hospitalizations, and no sort of curative therapy, and just therapy that is focused on promoting the person's comfort and not prolonging life. So I'm oversimplifying a little bit, but that's the basic idea of hospice. The goal is to concentrate on quality of life and symptom relief and so on, and not to prolong life with aggressive medical interventions.
Okay.
So beyond that, hospice care, it's team-based care. It includes a physician, nurses, a social worker, chaplain, or spiritual care counselor, and it also may include other professionals from other disciplines. And another thing about hospice is that they will pick up the costs of medical equipment and also any medications that are related to the person's terminal prognosis. So treating any of this kind of serious medical conditions that they have, in addition to whatever their sort of nominal terminal diagnosis is, or primary hospice diagnosis. So basically all hospice care is palliative care. The care that people receive on service with hospice is palliative,
Okay.
but not all palliative care is hospice, right? So, so really anyone with a serious medical condition and unrelieved symptoms is a candidate for palliative care. Now, similar to hospice care, palliative care also involves team-based care with a variety of team members who work with the patient and the family, just like hospice. And it's not just the patient, but their family, to alleviate symptoms of all kinds. Basically, using medication, whatever other strategies, and we have lots of tricks up our sleeve to relieve symptoms. Also, there's a focus on advanced care planning and kind of defining goals of care ahead of time. Uh, and it involves not just physical pain, but also spiritual, emotional, and existential sorts of discomfort. Now, palliative care, since it's not a specific insurance benefit, doesn't explicitly cover the costs of medications, even though palliative care clinicians often prescribe medications, but it's not covered in the way that hospice will actually, have the meds delivered to your house at no cost. Um, and one very important point to make is that palliative care can be given alongside curative care, right? So, um, chemo, transfusions, dialysis, hospital stays, and things like that. Um, that does not disqualify a person from getting palliative care. So, really, people who don't qualify for the hospice benefit, either philosophically because they're not ready to give up curative care, or prognostically, let's say because they've got longer than a 6-month life expectancy, still can get palliative
Okay.
care. And then the third thing you asked about end of life care. Sorry, do you have a
No,
question?
right.
No.
That
It's
made
a very clear explanation.
yes, that was a great explanation. And then end of life is
Oh, thanks.
would that be like just the last couple of days?
Well, it depends. It might mean different things to different people. Just like, when you say somebody has a terminal condition, that might mean, 6 months to one person, even a medical person. It might mean 1 year for other types of things. And for other people, I mean, if you've got, let's say, advanced Alzheimer's dementia, you have a terminal condition. You might live a few years, but it's still a terminal condition. So end of life care, normally it would refer to care and treatment in the final stages of a progressive illness, whether you say that's the last hours, days, sometimes even weeks or months, people might still categorize that as end of life care. And some people would say that hospice care, just by the nature of it, is end of life care, even though some people live on service with hospice for a year or two, or much longer than 6 months. So, and also for some people, end of life care may be in an intensive care unit on a ventilator, whereas for others, and probably what most people would prefer, is receiving end of life care at home in their own bed.
Thank you. Thank you
thank
for
you.
straightening me out.
And Karl, this is Jean Marie. I'm curious, how might palliative care benefit the patient and their family? You said that families included. How might the family benefit from palliative care as well?
Yeah, and that's a great question. I'm glad you asked that question. And of course, I'm a little biased. I mean, I'm a palliative care specialist, and I get to see on a day-to-day basis the remarkable benefits that patients and their families get from palliative care. But I mean, some of the most obvious benefits are for the patient, specific improvements in symptom management, especially with pain, but also lots of other issues like nausea, constipation, itching. There's all kinds of physical symptoms and emotional symptoms, depression, anxiety, and so on. And we have some great tools to treat those. And I want to mention, not everyone needs specialty palliative care. I mean, primary care doctors, other specialists like oncologists or pulmonologists, they're often able to manage symptoms, and there's really no need to call in a palliative care team or a palliative care specialist. But when they aren't, if symptoms aren't controlled, then that's a time to consider a palliative care consult. And advanced care planning helps. Palliative care can help people define what's important to them, and that is both the patient and their family. and helps them make informed decisions about what treatments they want and what they don't want ahead of time, right? Instead of kind of waiting for a crisis to make these
Mm-hmm.
decisions. And so that's one of the greatest gifts. I mean, in addition to obviously having a team of providers that helps with actual care, um, that helps the family in terms of offloading some of what they have to do. It also will help family members feel comfortable when somebody gets closer to the end of the line, and that they are, like a lot of people before they die, they lose the capacity to make and articulate medical
Mm-hmm.
decisions, right? And so this can help family members feel comfortable that they are really honoring the wishes and respecting what their loved one would have wanted. So that is a huge gift. Um, so one thing, a lot of people aren't even aware of the existence of palliative care, right? Or if they are, that they hear the word and they conflate it with hospice, and they're like, "Oh, I'm not ready for that yet," or that kind of thing, and they may be reluctant to mention it to their regular healthcare team. So I would just say for the listeners, if you or someone has a serious illness and whose symptoms are not being managed well, or even if you just feel like you need more information about what to expect as things go, things progress in the future, don't be afraid to at least ask for a palliative care consult. And not every location has easy or ready access to a palliative care team, but a lot do. And a lot of hospices provide palliative care that's short of the actual hospice benefit.
And
Oh,
I think the first time that we heard about palliative care was through a guest, and she said that the reason why it was offered to her and that she was able to access it and it was so readily available was because she was receiving care at a children's hospital and that it was a pretty standard of care there.
Yes, it's more common, I think, in pediatrics, and part of that is because it's just so difficult when you have, a child that has a really serious illness or that or terminal illness, um, and so it's very, very hard on families and so on. And so I think it's sort of natural that they would have a more of a robust team to take care of those
Okay.
people.
Okay. And how can someone access hospice or end of life care?
Well, for hospice, I mean, anyone who has Medicare Part A, which you automatically get when you turn 65, and you can also get it if you've been disabled for a couple of years. Um, Everybody gets Medicare A, so you don't have to pay anything for it or that. So, um, you know, if you ask for it, you ask your doctor, am I a candidate for hospice?
Mm-hmm.
And that, um, you know, presumably, if your doctor isn't sure, they can at least put in a hospice referral or a consultation, and the hospice people will be experts in figuring out if you qualify for that or not. Now, you'd still have to meet the other criteria, right?
Mm-hmm.
The 6-month life expectancy and being willing to forego curative
Okay.
treatments. As far as other types of end of life care, again, I think the best approach is to um, ask your regular care team. And if your doctors, some doctors aren't comfortable with
Mm-hmm.
it. Doctors, a lot of doctors have a tendency to really overestimate their patient's life expectancy, and that can be a real disservice to people, right? And I can't tell you how often. Most of my clinical work is in nursing homes. I cannot tell you how often I see somebody. They're 95 years old. They've got severe chronic kidney disease, like this close to dialysis. Um, they've got severe COPD. They're on oxygen and so on. And their primary doctor, their pulmonologist, their nephrologist, not one of them has ever once mentioned, "Hey, what do you see in the future? What do and what is important to you in the future?" And I mean, it blows my mind. I understand that there's a limit to how much time they have for their appointments and so on, but it just seems like such a disservice to ignore that and somebody who clearly is nearing death, right? And so I think it's important. Sometimes people need to clamor for it a little
Okay.
bit, and some doctors don't want to bring it up because they're like, "Oh, I don't want to be a Debbie Downer. I don't want to take away hope or things like that." And um, studies have shown patients really appreciate when these things are brought up because let's face it, they've been thinking about
But
it.
you have to face reality.
And if they
Right,
haven't,
right.
right. And if they haven't, they should be thinking about it, right? Yeah.
And studies have shown that 95 is a pretty old age.
Well,
Well, I just went through this with my mom, who passed away about a year and a half ago. And thankfully, she had all this stuff taken care of with hospice and directives and all of that, including the financial end with an attorney, which made things so much easier. But if you don't have that in place, it just can be so chaotic at a very horrible time in life.
Right.
Yeah, no, that's a gift. That's a gift she gave to you, and that's a gift that all of us, if we have kids and heirs or what have you, that we can do for them.
Good point. I read when we were trying to do a little bit of research on this episode that there are different levels of hospice care. Could you tell us about that?
So hospice has four different levels of care, and I don't want to get too carried away with the minutia
mhm.
of it, but just so people understand, hospices get compensated through Medicare A, and they get a per diem amount depending on what level of care the person is on. So, uh, it doesn't correlate exactly to how much money hospice may be spending on medications and equipment. It doesn't make a difference, how often they're sending a nurse out and so on. There's a set amount that they get based on the level of care. So the most common level of care is called routine home care, although it can be given in other care settings, including nursing homes and assisted living. And this level requires, at a minimum, a nurse visit once every 2 weeks, although often it may be considerably more than that. And it also requires an interdisciplinary team meeting where the case is discussed every 2 weeks. It has all of the disciplines on it. And so, and this almost always includes a home health aide, although once in a while people don't have a requirement for that. But that's somebody to go out and help with bathing and those types of things. The second level of care is called respite care, and this is where basically it's to offload the family or whoever the primary caregivers are for usually up to about 5 days at a time. It's generally done in a nursing home. And it just gives the family a little time off from their caregiving duties, or if they want to go make a trip for a few days, that type of thing. The third level of care is called the inpatient level of care, and this can be done either in a hospital or in a nursing home as long as they have a 24-hour registered nurse on site. And this requires that the patient have symptoms or medical conditions like maybe wounds or something that meet the criteria for being hospitalized or in a nursing facility. Usually, inpatient status will only last for a matter of a few days, while the symptoms are getting under control or what have you. And then the last and highest level of care is called continuous home care, sometimes called crisis care. And this also can be given either at the person's home, or sometimes it's given in like a nursing home or in a assisted living type setting. And this also generally involves sort of uncontrolled symptoms that require really intensive management. And this requires that skilled hospice personnel be physically present in the home or wherever the patient is for at least 8 hours out of the 24 hours.
Oh.
And sometimes it's considerably more. Sometimes it literally is continuous care, but people hear continuous and they think that it's going to be
Round the
around the
clock.
clock, which generally hospice doesn't cover that. Now, the inpatient level, some hospices, although it's a very small minority of hospices, have what they call an inpatient unit, like a hospice house or something like that, where they can put people for a few days to get symptoms under control. And that is a nice thing, because most people would rather go to a hospice house than go into a nursing home.
Sure.
Okay.
Sure.
Thank you.
Thank you.
So, Karl, I'm going to try and ask this. What's the purpose of physician orders for life-sustaining treatment? I guess it's POLST, or
POLST, yeah.
POLST, or medical orders for life-sustaining treatment? I guess MOLST. And how do those compare to, say, an advance directive?
Yeah, I'm so glad you asked that question. I just happen to be president of the National POLST Collaborative, which has all of the states. The states each have their own programs, and I'm going to try to compress my usual 45-minute lecture into a couple of high points for you.
Okay.
But so first of all, yeah, an advance directive is a document that probably most importantly tells the healthcare team who it is that you would want to make decisions for you
Hmm.
if you lost decision-making capacity, right? It also may include things, more specific things like I don't want to be on a feeding tube, or I don't want my life prolonged if I'm terminally ill or in a coma, stuff like
Does
that.
that include a
Everyone over
DNR?
18.
I'm sorry, I don't mean to interrupt. Does that include the DNR?
Well, no, no, it's, I'll explain why in a
Oh, okay.
moment, but um, now you can certainly say, I don't want my life prolonged. I mean, you can write in, you could say, I don't want resuscitation in your advance directive, but it doesn't have it's not a doctor's
Hmm.
order, so it's not something that can be followed.
Oh,
But anyway, everyone over 18 should have an advance directive. So, Jean, Lita, Ron,
Hmm.
do you all have your advance directives
I
prepared?
do. And
I don't
actually,
mean to put you.
in mine, I get a
no,
reminder every year to update it.
no, I don't.
That's excellent.
I
Somebody's
have
got to
Yeah,
get me going.
Okay.
because
I got legal documents going,
yeah,
but
these
not
Okay.
the medical documents.
Yeah, I've got to do that.
right,
Dominic?
right, and
Oh, okay.
We got to get him too.
Yeah.
I'll
right.
go first
Well,
'cause since I'm oldest. I'll go first.
Well, I think it's important to have it on the age.
Yeah. No, I'm just saying that I got more years behind me without it, so
Okay.
I got to get on the stick here.
Hmm.
Yeah, it really is a good idea because really, again, the most important thing is, and I'm not trying to cast any shade on anyone's spouse, but all I can tell you is that in real life, sometimes your spouse is not the best person to make medical decisions on your behalf. I can't tell you how many times I've seen, you know, I know that my husband wouldn't have wanted a feeding tube, but I can't let him starve. Put a feeding tube in him,
Hmm.
and those are very difficult decisions. So just make sure you choose the right person. Make sure you let the person know, but you want someone who's going to be able to advocate for you in whatever direction is appropriate to the circumstances. But anyway, uh, so so an advance directive, living will, or power of attorney for healthcare, it's not an order. So, like you said, Ron, so you might say, I don't ever want
Right.
CPR because I've seen what CPR does to people. But if it's just there in your advance directive, that might be something that they can take into account when you go to the hospital and write DNR orders. But outside the hospital, it's going to be of no value. Um, it's basically just a legal document that is expressing your wishes. Now, a POLST, on the other hand, and I'll say a little bit more about POLST. Uh, POLST used to stand for Physician Orders for Life-Sustaining Treatment, although they've tried to do away with that language for a couple of reasons. One being it's not always a physician that signs it, and just the notion that life-sustaining treatment is kind of value-laden, right?
Hmm.
Because I can tell you that doing CPR on an 83-pound, 102-year-old is not life-sustaining, right? I
Hmm.
mean that they're not going to survive it, and so now we just call them portable medical orders,
Oh,
and
okay.
and so yeah, but we've kept the acronym POLST, right? And just to make things even more confusing, different states have a lot of different names. You mentioned MOLST and
Hmm.
POLST.
Right.
There's also COLST, and there's POST, and there's TPOP, and literally there's 13 different names.
Wow.
And if you're interested in more, you can go to the POLST website.
Okay.
It's POLST.org. And you can see all the different states and what they call their forms. But they all do pretty much the same thing. And I want to emphasize these orders are not for everyone over 18. These are really for people with serious illnesses. We sometimes use what we call the surprise question because they're medical orders. This is the kind of thing you expect your doctor to offer, but sometimes patients need to go in and say, "Hey, would you do one of these for me?" Um, but they are for people. So the surprise question is, would you be surprised, doctor, if your patient died in the next year or two? And if the answer to that question is no, then I should be thinking about at least offering a pulse to these people. Um, And they're generally for people who want to avoid certain kinds of treatment, like CPR, let's say, or being on a ventilator. Um, and CPR, by the way, it's not like it plays out on TV, right? Where the 85-year-old woman is in the hospital, is in a restaurant. She has a little cardiac arrest, and they do a couple of pumps and give her a little jolt, and then she's dancing out of the hospital the next day. And that is not real life. Um, Out of hospital cardiac arrests with CPR, especially in say a nursing home population, but just in the public at large, unwitnessed arrests almost never survive. So, um, but anyway, uh, now POLST also, if there are those limited number of people who truly do want the most aggressive treatment, it's like, I don't want to die. I want my life prolonged till the last possible instant that medical technology can offer. They can fill out a POLST that says that. So it's not just to limit treatment, but it's mostly used for people who want to limit their treatments. Um, and so these orders have to be signed by a doctor, or in some states, nurse practitioners and PAs can sign them, whereas an advance directive just has to be witnessed.
Okay.
Oh,
But in any event, yeah, for a great majority of the population, people like you and me, who would certainly want at least an initial attempt at aggressive resuscitation, we don't need a POLST form because we healthcare providers assume everyone wants that. We don't need a piece of paper to tell us that if you collapse, we're going to try to revive you. But if you don't want CPR when your heart stops beating, you probably ought to ask your doctor for one. And one of the most important points I like to make before we lay this to rest is that when people see DNR or DNAR, anyone know what that
No.
is?
do not attempt to resuscitate.
Do not attempt
Wow.
resuscitation.
Ooh, I
Right.
win.
He wins.
All right, wait. Here's a harder quiz question. What about AND? Beep. Okay, that means allow natural death, and some
Oh.
POLST forms have that on.
Yeah.
Um, and to me, that's almost value laden in the other direction. It's like allow natural death. That sounds so nice. Like who doesn't want a natural death? But anyway, when you see DNR, or AND on a POLST form, it has a very specific meaning. It only kicks in when your heart has stopped beating. Like basically, when you have no pulse, you're not breathing. So it does not mean that if you're struggling to breathe or if you lose consciousness, that we are going to just stand there and watch you as you're gasping for breath because you have a DNR order, right? It only applies to doing chest compressions if there's no pulse, which
Okay.
I learned in medical school. If you don't have a pulse and you're not breathing, you're dead,
Right.
right? So basically, DNR on a POLST form means if you find me dead, let me stay dead. Don't try to bring me back, right? It doesn't mean stand there and watch me gasping for breath and say, well, he's a DNR, so we're not going to do anything. So that's really important because sometimes people are reluctant to sign that, especially about a loved one, because they're like, well, I know what DNR means. It means just let me die. That's not true at all. You can be a DNR on a POLST form and you can still be full treatment, which means, for example, if you have a respiratory arrest, you still get intubated. It's just at the moment your heart stops beating, we don't start pounding your chest
Okay.
and
That's-
doing CPR.
That's amazing because I never knew any of that.
Oh, okay. We're glad that.
Good. That's
Yeah.
Well,
That's
glad
what
to
this
help
is
out.
for. Yes, I'm learning a lot today. Can I ask who might be part of a palliative healthcare team?
Yeah, so it's really variable, but typically there'll be a doctor, PA, nurse practitioner may be part of the team, nurses, both registered and licensed nurses, home health aides, social workers, spiritual care counselors, sometimes therapists, PT, like physical therapy, occupational therapy, speech
Recreational
therapy,
therapy. I'm
maybe,
sorry. What did you say?
You're
right,
talking to
and
two
maybe
recreational
respiratory.
therapists.
We're
yeah.
both recreational therapists, so
Oh,
we
bless
gotta get in
you.
there. Yes. Go ahead.
What a great gig you have. Thank you for your service on that. That's
Well, that's
you rack up a
you
lot
know,
of karma.
this is how I'm continuing my rec therapy is by providing a platform for a lot of people to learn about different diseases. But Ron is still working in the field.
I don't.
I'm retired.
Other than the adapted scuba diving, I actually work at a facility in Chicago where we have young adults with physical disabilities to get them as independent as possible as they transition into adult life, which includes a lot of activity therapy type stuff where they can do the same things out in the community as their peers.
That's great.
That's fantastic. Well, God bless you both for that
Thank
good
you.
work that you do.
Thank you.
Thank you.
Oh, my turn. Sorry.
Okay.
So, are there limitations? Are there certain limitations in providing final health options for people wishing to die at home rather than going to an extended care facility or a nursing home?
Yeah, well, that's a complex question, and I mean,
I always
there
ask
are
complex questions. I always ask the hard
Yeah,
ones.
yeah, I usually give you the hard ones.
Or those that are difficult to
and
pronounce.
yes, well, most people, about 70% of Americans, when they're polled, say they'd prefer to die at home to then, to die in an institution of whether that be a hospital or a nursing home. Of course, there are those who don't want to die at home. And, as far as limits, I mean, it's a lot of it has to do, and it's a serious equity concern, is it has to do with the financial resources. Sometimes it also has to do with human resources. How many family members do you have that might be able to help out? But if it involves bringing paid caregivers into the house, hospice does not cover 24-hour care. So they may send a home health aide
Hmm.
3 days a week, 5 days a week, but that's not enough to allow somebody who's completely dependent for all of their activities of daily living to stay at home. So, and just getting back to some of the other treatments that are sometimes used in palliative care, there's music or art therapy, there's reminiscence therapy of various types,
Hmm.
Reiki, acupuncture, massage. There's really no limits. And some people get a death doula, if you've heard of that.
Yeah,
There's
yeah,
the
I
doulas who help
recently
with
heard about
births.
that. Yeah, it's like
Yeah,
a birth
and
doula, but the
they
opposite. Just
that's
somebody to
right. They're
help guide you.
helping you. Yeah, to help you exit this
Oh,
plane of
wow.
Yeah.
existence as opposed to enter it. Yeah, and hospices may or may not cover these services. Sometimes they may have a volunteer who provides these services, and
Sorry,
you
I'm
know,
sorry.
it's worth
Go ahead. I
if
my
you're
sound
if
engineer
you
was telling me I can't talk from way back there. I'm so sorry.
oh um, no problem. But so if you are, in the process of, say, interviewing hospices, and I encourage anyone who's contemplating hospice to at least, I mean, if you're the kind of person who, when you're about to get work done on your house, you get a few estimates, interview a few different hospices and ask them what they provide. Um, and there are some websites that help you pick hospices. So it's an important decision, and most people are very happy with the care they get from hospice, but not everybody. And there's been, there's private equity now with these so many for-profit hospices, and I'm not saying for-profit hospices are bad, but um, there may be anyway. Just
Hmm.
Mm-hmm.
do a little bit of
Understood.
research.
Mm-hmm.
Yeah.
Okay. And you already touched on this briefly, but what services are provided for palliative care compared to hospice care?
Yeah, well, hospice care has required services, right? I
Okay.
mean,
Sure.
so they have to have a doctor, they have to have nurses, they have to have a chaplain or spiritual care counselor, and they have to have social work. Not everybody will utilize all those services, but they have to offer all those services. Palliative care, totally different because it's not a set benefit. So I like to say you've seen one community-based palliative care program, you've seen one community-based palliative care program,
Okay.
and a lot of them are sort of what I would characterize as palliative care light. I mean, I've seen some where basically it's a social worker who calls the family once a month or calls the patient once a month to see how they're doing. Um, and whereas others have a really robust program that would have everything that the hospice would have. So again, and you may not have a lot of choices in your particular market or your community, but um, some palliative care is better than no palliative care, right? No matter how many people are on the team. Um, and presumably eventually you transition to hospice when you either meet the prognostic and or well, you have to both meet the prognostic and the philosophical requirements.
Okay.
All
Thank
right,
you.
thank you. I read, again, while I was researching this, that the nation's 65 and older population is projected to nearly double in size in the coming decades, from 49 million in 2016 to 95 million people by 2060 that will be 65 and older. So, based on these numbers, can you tell us what the future of palliative care is? I mean, it sounds like
You might
there
be
might
overwhelmed
there might be a need for new doctors in this
in this
arena.
field. Yeah.
Yeah, yeah, it's definitely a boom, and it's a little scary. I mean, and it's just like with geriatricians. I mean, there's a huge shortage of geriatricians, uh, and there's also a huge shortage of palliative care specialists that is not expected to improve anywhere near enough for everyone who might benefit from palliative care to have access to a specialist or to specialty palliative care. So while we'll continue to see growth in palliative care services, and it has become a more popular specialty with young people, when they finish their residency in some other field, some of them, they do a fellowship in hospice and palliative medicine, but it's not going to be enough to fill the need. So I think it's going to be really important to educate our primary care workforce and other specialty doctors and other practitioners on basic palliative care principles, because they're going to have to be doing a lot of that work, right? Symptom control and advanced care planning and those types of things. And I'll just say, I'm 65, right? So I just got my Medicare benefits, and it scares me that, and this isn't just doctors. We have a huge workforce shortage. Nurses and nursing assistants and so on. Nursing homes are having the hardest time staying staffed, and I don't have an answer to this. So
I'm so
Hold
sorry.
on,
I'm so
excuse
sorry.
me. 1 minute.
I'm so sorry.
Well,
what a
they're
treat!
attending to
I'm
the
so happy to have someone else's dog making noise instead of
Oh,
mine.
well,
Thank you for that.
Yeah.
Rita's tending to the dog. I mean, I'm hearing this, and I actually have a friend in a nursing home right now, and I mean, in my opinion, bottom line is a lot of it is economics. There's not a lot of money in that field unless you are like the owner of a nursing home or some, because they don't pay their staff, and there's a lot of turnover. It very frustrating. Again, it's from a personal standpoint, but I just think that with the population living longer, that there should be more emphasis put on care for people as they get older. All right, rant over.
Agreed.
Okay, I'm
Yeah.
back. Sorry
So
for
sorry.
the guard dog interruption.
And he's not even supposed to bark.
No, he doesn't normally bark.
No.
So this surprised
I'm
the
so
heck
sorry.
out of me.
Yeah.
Where am I?
Where are you, Mom?
Oh,
You're
okay,
here.
I'm right
It's
here.
Okay.
All right. I'm back.
Okay, that's good.
Well, okay, I missed a little bit of your answer. However, I was curious, do you think that a palliative care for dummies would be a good book for what? Well, listen, for family members to know what they might need so that they can pick and choose, because it might be a shopping expedition for people in the future. They might want to pick and choose different. I'm just saying that,
Okay.
people, regular people like us,
Mm-hmm.
how do they know what palliative care resources that they want,
Well,
that they need?
Yeah, I think it's a really valid question, and I think there's a big knowledge gap. Most people don't even know what palliative care is, and those who do think it's hospice. A lot of them do, even doctors, right? In the hospital, when somebody says, well, maybe like a nurse might ask a doctor, an intensive care doctor, hey, maybe we should get a palliative care consult. This person, on the ventilator, they're, whatever, they are uncomfortable, or the family's struggling, and why don't we get palliative care? And an intensivist will say, oh, they're not ready for that yet. It's like, what do you need to be ready for it? You have a serious illness, anyone with a serious illness would be appropriate to at least consider palliative care. So I think part of it is, and I'm working with a group called the Message Lab, which is through University of Washington and the John A. Hartford Foundation, with a lot of really cool national organizations, and I'm working with them on behalf of National POLST. But there's sort of a messaging issue, right? People don't know what palliative care is, or it's got a negative connotation. It's it's conflated with hospice, end of life, death, and those kinds of things. But I really think if the public knew what palliative care was, people would be clamoring for it.
Oh, yeah.
And so I like your idea about, palliative care, just something, basic palliative care knowledge that people would have in their back pocket so that when they or their loved ones are struggling with a serious illness, that they could actually ask for it.
Now, I don't mean to really oversimplify this, but as people get older and hopefully they're going to their primary care, that there might be a handout or
right.
something
A
like
pamphlet,
that.
right.
Not that the doctors have to be completely well versed in explaining the difference between hospice and palliative care. But for example, I'm having a surgery myself coming up, and the doctor gave me a booklet of stuff, and I'm reading through it, and I'm like, oh, this is what this is. Oh, so that way somebody goes to their PCP, and in there's a handout, a brochure, a pamphlet talking about palliative care as an option.
Right.
Again, I don't mean to
Yeah. Well, I'll tell you,
oversimplify, but it's just knowledge.
Right.
yeah. Well, and I think a lot of the palliative care programs do have handouts like that. But the trouble is that by the time they're handing those things out, the
And
person's
people already know about
in
it.
there.
Right.
And also, I mean, even if they hand them out, let's say at the cardiologist's office or the oncologist's office, because oncology is a place where, eventually, if cancer progresses, right, that you're going to eventually be appropriate for hospice and
Right.
so on.
Right.
Um, but if they don't hand out those things because they don't want to take away hope, or then it's not going to get into the proper hands. And I would encourage, this website for the Message Lab is a really cool website. I believe it's seriousillnessmessaging.org. And it's got some very, very nifty stuff. It's probably mostly for healthcare providers, but it would also provide a lot of interesting facts to just regular people who might be interested in finding out more about palliative care.
Okay.
Great.
Thank
Thank
you.
you very much.
I'm going to switch gears just a little bit. Carl, how can the medical community help families make the transition to dying at home rather than placing somebody in a nursing facility?
Well, the first thing to do is ask, right? I mean, the medical community, which means let's say if you're in a hospital and you're sick, and it's the doctors, it's the discharge planners, social workers. Ask people, what do you want to see? How do you see things going down in the future? Sooner or later, all of our hearts stop beating. Where would you like to be when that happens for you? If you don't ask that, then the assumption is that if you're medically ill, you should be in a medical facility. So if it doesn't get asked, then it doesn't get answered, right? And but I do think engaging with hospice, that is something that they are experts on. And if there's a way to do it, hospice can help a lot. But again, hospice doesn't cover around the clock care, or usually even
Oh,
daily care.
okay.
So
Yeah. Yeah.
so
And,
much of
and
it
a lot of
depends.
people might not be able to afford to stay at home. Okay.
That's exactly it. It's going to depend so much on what other resources a patient and their family can muster, for those final days. And, sometimes people, some states have this medical aid in dying where if somebody is terminal and they want to end their lives and not, march from point A to point B and just end it before things get bad, they have that option. The doctor can prescribe, sort of a lethal cocktail. And in other states that don't have that, people always have the option to do what we call VSED, or voluntary stopping of eating and drinking. But that takes a long time, right? I mean, you swallow this cocktail, you're gone in an hour or two. You stop eating and drinking, it might take 2 weeks,
Yeah.
right? And
And that's got to be
that's
painful
that
too.
can be Well, I don't know. People don't seem to have a lot of pain from it, but it's probably painful for the family.
It
At
goes
the
against what we,
bedside,
yeah, we're
Our
used,
nurturing.
right,
Yeah.
right.
all of that. But right. I mean, it takes a lot of resources to because you have to turn and reposition the person, and at least at the beginning of something like that, they're going to have bowel movements and they're going to urinate and things like that, and so that's a lot. But really, the simple answer to your question is, I think the medical community can help families by supporting them and by helping. Make referrals to agencies that can help with home care. A death doula might be a really good referral to help people figure out if that's something that's going to be realistic. And of course, the hospice.
Okay.
Thank you.
Thank you. And I think we already talked about what I was going to ask, whether or not there are instances where a person might not be able to actually choose to have their end of life care provided in the home. But I think we just covered that
Yeah,
adequately. Thank you.
Well, and not only that, but I mean, there are also people, like I said before, there are a limited number of people who don't want to die at home for whatever reason. Maybe they don't want to. They're going to sell the house. They don't want to put it on the disclosures, after they died, or they don't want to burden their
Oh,
spouse with the memory of them on their deathbed with their face all
right.
drawn up, and any number of reasons why somebody might not choose to do that. And I just again want to point to that equity issue is that for people of means, it's not that hard to die at home because you can pay for extra help.
Right.
But for a lot of people, it simply isn't an option, no matter how much they would prefer to die at home, and it's unfortunate, but that's the world we're living in.
Thank you. Well, I think we already covered my question too. That people should include hospice or palliative care when they're doing their advanced directives. So I'm going to push it
Yes.
back to Ron.
Pass the baton.
All right, I'm going to serve this next question up.
Oh boy.
We've heard you like to cook. What role does nutrition play for patients in palliative or hospice care?
Well, first of all, I have no idea where you heard that rumor because nothing could be further from the truth.
you guys
If popping a
just
quesadilla in the
Yeah.
microwave,
Okay, but you do play
yeah,
and have dogs, correct? Or
I do.
okay,
Yeah, I
I was
take my
gonna say.
dogs to the nursing
Okay,
home.
otherwise I might be fired.
Yeah.
Can we scratch that question
Yeah.
because I feel like a real ass now.
No, no, no. It's okay.
That is hilarious. No, that really tickles me. Thank you for that. I wish it were true. Maybe someday. But no, nutrition is important. I mean, nutrition because it helps people feel better. But when people are getting close to the end of life, they typically lose interest in food and in fluids. And we basically let people eat whatever they want. If they want to be on an ice cream diet or a brownie diet or whatever it is, we let them have whatever
Quality
they
of
want.
life.
And
Right.
that's right. And one thing is that when people take in a really inadequate amount of nutrition for a long period of time, they tend to get complications like skin breakdown, like pressure sores or bed sores. And so sometimes it's better if they're really only taking in a very small amount to just
Ensure.
have them not take anything.
Okay.
What's
Okay.
that?
Yeah, I was just thinking maybe just a bottle of Ensure just to give you the nutrients that you need and liquid, but
Yeah, if people like that stuff, and some people really do like those. I mean, I sort of like the taste of them. It reminds me of an instant breakfast that I used to have when I was a kid.
yeah,
And
that's exactly what they
protein
taste like.
drinks. Yeah. Protein drinks can be helpful. Now, when people have like an advanced malignancy, you take in the calories and the protein, and sometimes the tumor kind of preferentially gets it, and it might actually make the tumor grow faster. But that's not a reason. If somebody's hungry and wanting to eat, then of course you feed them.
All right. And what advice do you have for an individual or family if the end of life is expected within a year?
Well, one thing is your doctor may not always tell you when they expect that your prognosis is poor, which is unfortunate. Even if they are thinking it, they may not volunteer that. And also, again, doctors tend to overestimate their patients' life expectancy. But if when you feel like your life may be ending within the next year, or a family member, it's time to start making sure that you've got all of those affairs in order. If you don't want CPR, if you don't want to go to the hospital, and again, palliative care or hospice would probably be the best ways to make sure that you have all that kind of lined up.
Okay.
I'm going to add one thing to that, and I found this out the hard way. With the DNR, if you have that, post that on your refrigerator or somewhere where it can be seen. Even though my mom had that, I did not have it handy. And when the
They don't have a
EMTs came, thank God they did not. But I screamed at them. But I did not have it handy. So I guess my PSA would be, if you have it, make it visible, know where it's at in case, not in case, but when you're put into that situation, so that you can present that to the firefighters or the EMTs that want to come and
Pound away. Yeah.
Exactly.
I'm really glad you mentioned that, Ron, because and you were really fortunate, because they really can't. They're very protocol driven. So even if you had an advance directive that said, look, my wife says I'm the one to make decisions on her behalf and she doesn't want CPR, they still kind of are obligated to do it, because that's just what they do, unless they get a base station doctor to kind of call them off. Whereas if you had the POLST form or a pre-hospital DNR, then they can follow that because it's a doctor's order. But yes, we always tell people, put it either on your bedpost or right on your fridge. And I like to say, every time you go to the fridge, there it is. It's like, okay, I'm going to have 2 pieces of cake instead of one, right? Since I'm going to be dying soon anyway. But yeah, and then there are a lot of electronic registries for these things now. In most states, POLST forms, a sort of a replica of it is valid. So a photocopy, a fax, even a picture on your phone.
Okay.
So if you have that, for people that are really serious about not wanting some of these interventions visited on them, that can be super helpful to, you sign up for one of these websites like mydirectives.com, or there's a bunch of them. You can Google that.
Thank you.
And Karl, I have a question. What role should pets play in end-of-life care, and do their future care is that something that should be addressed by families as well?
Yeah, well, and again, I take my dogs to work with me, one or both, to the nursing homes with me on a very frequent basis. That's like one of my claims to fame in San Diego County, and they certainly bring so much joy to so many people, and I love that I can do that as part of my job. But for most people who love their pets, part of their picture, if they got to envision what their death will look like, would be in bed with their beloved pet lying next to them and their family, around the bedside, and so on. And those are things that can be planned for. And hospitals, especially if somebody's like on a palliative care unit or getting hospice care, a lot of hospitals will let a pet in when somebody's actively dying, and nursing homes, same thing. But if you're asking, like, should people be planning ahead for their pets as part of their estate planning? Absolutely. You should talk to your family, just like you want to talk to the person who's going to be making medical decisions on your behalf, to make sure they know what you want. You want your family to know who, if you die, and this is for people of all ages, right? That who you'd want to take the pets, and make sure that they're willing to do it, and maybe even set a little money aside to help with that if that's appropriate.
Good point.
Excellent. Thank you very much. Well, Dr. Steinberg, I'm going to go back to your official name. We really appreciate you taking the time to join our show today. How can listeners learn more about you and what you're doing out in the world?
Oh gosh, well, hey, I'm at the AMA House of Delegates in Chicago this week, and no, if you want to find out, just Google me, right? It's Karl with a K, Steinberg, and I'm on LinkedIn, I'm on Twitter, although I'm sort of ambivalent about Twitter these days, but there's actually a fair amount of good medical information on Twitter if you can sort out what it is. And my Twitter handle is at Karl Steinberg, KarlSteinberg.
Thank you.
Okay.
Thanks so much for having me. I enjoyed this.
I'll pick you up for lunch tomorrow.
Unfortunately, I'm sitting in the House of Delegates all day. Oh, it is mind-numbing. But you'd be surprised, the American Medical Association, other than maybe their stance on nurse practitioners and scope of practice, they are remarkably progressive on a lot of things, and I appreciate that. My parents were both doctors. They were lifelong kind of AMA haters. They were never members, and I was so pleased when I joined. I mean, it's been a long time now, but to see some of the really wonderful work they do.
Well, thank you.
It was fabulous having you. Thank you so much.
Yeah, we all learned so much.
Yes, and we will have all of the links that you mentioned on the webpage associated with this episode.
Yes. If you have any questions or comments related to today's show, you can contact us on our website, PodcastDX.com, where you'll find more information about this episode as well as all of our social media links.
And if you have a moment to spare, please give us a review wherever you get your podcast. As always, please keep in mind that this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment, and always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition or treatment and before undertaking a new healthcare regime, and never disregard professional medical advice or delay in seeking it because of something you heard on this podcast.
Till next week.